Anne, fantastic. Anne is giving some introductions.
Yes, welcome everybody to this education session run by CADQAS team. And today it's Dr. Corrado and Simona Costache that are going to explain everything about HER2 IHC in breast cancer. And as you may know, there will be another session about HER2 dualish at 5 p.m. later. Both will be recorded and posted via CADQAS website on the YouTube channel. And we are happy as Roche to sponsor this initiative, which is improving the quality of interpretation. And there are several modules all around the year, kind of once per month. So please have a look on the website. We will post the link in the comments and enjoy the session.
Thank you very much, Anne. So I'm here with Simona. Simona's task is to try and butt in and trying to say a few words to see whether she can manage that, because I will be a little bit kind of speaking too much. So your task is to summarize and perhaps ask the right questions, and also perhaps intervene when you think I'm not really very clear. So we're going to go through, let's put a nice pointer. How do you put a pointer here? Very good, laser pointer, laser pointer. So the agenda is to go a little bit through the current therapeutic categories that we need to recognize in HER2, give a bit of background on the clinical IHC test that we use, and then going strong on how to interpret these tests with some emphasis, and you will see why, on recognizing staining patterns. With the best intention, we should do this in half an hour, but there are 200 slides to go through. 211. However, at the end, the last 15 minutes, we would like to do some case studies with you, for which there is, Anna is organizing a polling question. You will need to be quick with the answers, and then we'll have 15 minutes for question and answer at the end. And then, as Anne said, following this session, there will be a training on DDISH immediately after, and we'll send you the separate link if you don't have it. Okay, so everybody gets disclosures. I don't really think this is important. So let me talk to you about model railways. I'm not really keen in model railways, but I thought it was a very good way of exemplifying what has been happening in HER2 immunohistochemistry in breast cancer. So round about 30 years ago, the model railway was constructed because we had to identify patients for treatment with Herceptin. And this was a fairly simple, basic model. There was a starting station. There was a kind of some exchange tracks where you needed to recognize as 1+ or so on. You needed to understand whether there was necessity for in situ polarization. And then the terminal station is HER2 positive, we can give Herceptin and now other things, or HER2 negative, back to the same chemotherapy, or perhaps more recently immunotherapy. That was great. And this is because the real task was to identify those tumors that had oncogenic mutations in HER2. These were early on changes in breast cancer cells that were pervasive in most of the tumors, so every cell carried this mutation, and the mutations were mostly gene amplification. And to be honest with you, we weren't very sophisticated at the time. We called it gene amplification. These were possibly amplification of portion of the genes or mutated genes that were then amplified, but it doesn't matter. There were a lot of these genes exemplified here by clusters of silver dots inside the cell. And the result of this amplification was that there was expression of the protein. Protein was a target, and it was biologically disturbed by the antibody of trastuzumab, and the patients were responding. So we need to sort out those that didn't have it from those that have. And peculiar to breast cancer, these amplifications were present in a significant number, not a big number, but significant number, let's say 10 or 15% of cases, which is why HER2 became very important in breast cancer, because HER2 amplification is present in a lot of other tumors, but we don't really talk about it. Here is a minority sport, 1%, 2%, but breast cancer, 10, 15%. So this was the task. And because in most cases, I'm talking about 95+%, the amplification was expressed, the difference in protein level was very telling. Okay, but a few years ago, the situation started to be complicated. And you can see here, we got another station. The station is the antibody-drug conjugate. And although there were early attempts to different antibody-drug conjugate, now HER2 has become very prominent in this arena. And therefore, we needed to identify tumors that did not have amplification, but had low level of expression of HER2, called appropriately HER2 low, that could be treated with this antibody. And then, of course, those that didn't have low level of expression, they were given chemotherapy. Chemotherapy has been rerouted somewhere else. A couple of years ago, things changed again. So we had to build new tracks, because we had to start to recognize also those tumors that had less than 10% of staining, because these are now familiarly called ultra low, because also some of these patients benefit from the antibody-drug conjugate. Situation is a bit complicated. These tumors are only at the moment the estrogen receptor positive, but nevertheless. So now the situation is more complex. Okay, so while for 25 years there was complete inactivity and things were either positive or negative, now there is an increasing amount of complication. So what do we do? What do we use to test clinically for HER2? We use antibodies, and we use a conventional immunohistochemistry. And I've worked out these diagrams to make you understand some of the pitfalls of this test, because if you understand it, then you are able to negotiate it. So this is a line that say more and more copies of HER2 per cell. This is protein. And this one here, about 20,000 copies. I'm talking about membrane expression. 20,000 copies is the ballpark figure of a normal breast epithelial cells. In fact, of a normal epithelial cells, because HER2 is a molecule very much pertinent to epithelial cells. So 20,000 copies. And our original target was to identify cells with millions of copies. For reasons that is beyond my comprehension and my understanding, the original IHC test decided, the people that created the original decided that we should not stain normal breast epithelium. So the limit of detection of immunohistochemistry is around 3,000 copies, but we wanted not to show any staining in epithelial cells, normal epithelial cells.
So we put the threshold.
So the threshold has been modified. Yeah. So in this clinical test, if you do this test, you see there is no staining here. Here there is a little bit of luminous staining. We can talk about this later, but the tumor cells stain strongly. Something that didn't stain was called zero, with terminology borrowed by the conventional histopathology terminology of calling things 1+, 2+, 3+ of 0. Those that stained a lot were called 3+. And then those that there were, let's say 10% of cases where the expression wasn't as high as we should expect, but it was higher, much, much higher than normal. So they were called 2+, and then everything else that stained, but not as much as 2+, was called 1+. That was clear. And in this case scenario, the target of our attention is to identify this population of patients. And this one was a fail-safe. Is staining maybe not enough? Let's do a second test. And the second test was the in situ hybridization. So if we visualize antigen-antibody reaction, so here there is, in the x-axis, there is increasing density of antigen on the tissue section. And here there is increasing amount of deposition of chromogen on the section. So the antigen-antibody curve in these cases is kind of has this type of shapes, maybe steeper or less steep. And the measuring is our eyes. Mm-hmm. And our eyes, pathologist eyes, goes, as we said, in pluses, 1+, 2+, 3+, or nothing, you know, 0. 0 means I can't see anything. It doesn't mean there is no staining. It's just no staining. There's below the lower limit of detection is here. The immunohistochemistry, although it will be asymptotic here, the chromogen deposition up to over a certain amount, I cannot tell that there is more. You know, so there is also a limit of it's saturated. I can't tell you anymore. Fantastic. So that's what the typical immunohistochemical staining. And if we use a normal immunohistochemical to demonstrate HER2, you'll see breast epithelium stains, weak but stains. Yeah. Now, what happens in the clinical test? We shifted the sensitivity, we decreased sensitivity, and the curves looks a little bit like that. So this is the clinical test. So now we don't see normal epithelium staining. Okay, that's cool. I'm happy with this. Little warning sign. Why? Because other clinical tests, so for instance, this, let's call this the Ventana IHC test. That's here, the blue curve. But other IHC clinical tests may be less sensitive or more sensitive. It doesn't affect the amount of cases we identified at the top end. They are all designed to be good at identifying that. But now that we need to score the low-level expression, they will be performing significantly differently. So be aware that there is this issue at the lower end of the spectrum. Is our clinical test reliable? There are hundreds of papers, dozens of papers, and I'm showing you one just to say, if you review the work in your laboratory, in many laboratories, you can do meta-analysis. In reality, with a two-tier classification system, positive or negative, there is excellent concordance. So these are cases that were stained with immunohistochemistry, stained also by in situ hybridization. 96% concordance is we're doing very well. Okay, and then when you look at the discordant cases, there are reasons for it. You know, some patients were on treatment with trastuzumab. Some patients have very close equivocal results, and the main issues in the small percentage of these cases, the main issue was about interpreting the stain. And I think this is an element that is repeated. The interpretation is the critical issue. However, we are quite good at interpreting the two-tier system. Yeah. We're quite good. And
but also we have experience with it.
And we have a long-term knowledge. Okay, so what is the interpretive algorithm? The interpretive algorithm, and this is one that we published with AstraZeneca, is a stepwise approach. Now, this is something you don't see in the published guidelines, but this is something that has evolved in the practice of histopathology. And now that HER2 law has come to fore, we had the opportunity to write it down and to think about it and to create a scheme. So we will talk about it more in details, but there is a stepwise approach where we use magnification system to determine staining intensity. Then we look at how many cells have those characteristics, and then eventually we come up with an IHC score that is written here. The IHC score is not the clinical diagnosis. Then the clinical diagnosis will be an elaboration of what the regulatory approval is for that particular indication. And at the moment, we think that we should identify the null, no expression whatsoever, the ultra low, a little bit of expression, but not as much as 10%, the low, this is 10% or less, or the positive. So the point is, the algorithm will give us an IHC score plus regulatory approval, diagnostic categories. These names will change. Some of these HER2 positive is an inheritance, is probably now a bit obsolete. We need to find something else for it. Ultra low, low, null, etc. This terminology will change, but you understand that these are our diagnostic categories. Is the IHC test reliable also for the low category? This is a big question. And in fact, there are a number of very good publications that show that we pathologists are not very good at recognizing this law. And I'll show you one only. This is relatively recently. This comes from the UK. These are the most experienced pathologists of the UK. They are called the Big 18. They are self-proclaimed big. But nevertheless, these are people with great experience. And you see here, they looked at the various cases, and you can see how much variation there is in the best pathologists. When we look at low, zero, etc., they don't agree with each other. So it is an objective problem that HER2 low is more difficult. And that's why, if you follow me, we will get much more concordance, because all we need to do is understand the rules. Once we understand the rules, I think we will all be able to put in the right thing.
Mechanism is and an approach, a systematic approach, how I like to call it. And I do think it never fails.
Yeah. Cool. So just a moment of reflection that because the low-level expression is this 10% threshold, the sampling will be important. And this is one paper among many that say, actually, if you look at the core biopsy status and compare with the excision, because the excision is a bigger area, there are less variation in sampling, etc.
You might switch to
and you see 42% is a significant change. Yeah. Okay, so be aware that there is sampling, there may be sampling issues with our core biopsy. Okay, good. Scoring algorithm, 3 elements: staining intensity, distribution of staining, and number of cell staining. We do it this side of the Atlantic this way, but the principle is the same. I realized that in the US, they do it the other way around. First, they look at distribution of staining, and then they look at staining intensity, but it doesn't really matter. Doesn't really matter. I think our way is best.
Of course.
Okay, so, I've kind of done this to try and update it with these new ultra-low things. So, 3 elements: intensity. And intensity, we have 3 gears: weak, moderate, and strong. To be honest with you, I think we should have 2 gears only: strong or everything else. But because everybody is already accustomed to the 3 tiers, let's keep the 3 tiers for a moment. We may want to lose the difference between weak and moderate in due course. Then the second element is whether the staining is partial or circumferential. And then obviously the amount of cell staining, and there is this 10% is a man-made threshold. So first of all, determine the staining intensity. We use the magnification rule. We'll have a look at it. Then we determine how many of these cells have the staining intensity and whether it's complete or incomplete. And then we get an IHC score. The IHC score, you see, 3+, then we can call it overexpressed. If it's 2+, we need to do something else. So usually in situ hybridization, it could be amplified. Both of these will be high expressors. It will be HER2 positive. We can treat with trastuzumab or anything else we like instead. If instead it's not amplified, this falls into the HER2 low category, as do all the cases that are 1+. These are low. And now we need to differentiate 0 with membrane staining or 0 with no membrane staining. And this is the ultra low. And this is the now. Okay. Staining intensity. That's my favorite part of the talk. This is Joseph, my friend Joseph Ushoff, and his magnification rule. I'm not sure that is his magnification rule, but definitely his insistence has created the fact that we all use it, you know?
And
so,
make people aware of it.
And make people aware. And Joseph is a great teacher, and he's trained a lot of people in HER2 interpretation. And he's done also a great amount of work in the gastric HER2, not just in breast HER2. Okay, so Joseph rule says that if you see a line, this only works for lines, by the way. If you're looking for cytoplasmic staining, nuclear staining, it doesn't work like this. But lines. Yeah. So if you see a line at low magnification, let's say ×2 or ×4, this is strong staining intensity. So this is the first time somebody says strong staining intensity. This is the definition, because otherwise we keep arguing with each other until there is
not strong.
If it's strong, if it's moderate, etc. If I have an intermediate power lens, and I can see only with the intermediate power lens, it's moderate. If I don't see anything at intermediate power lens and I need to put a high power lens, that's a weak staining intensity. That makes sense. Now, there is a physical reason, and I'm going to show you this because I don't want you to be too hung up about magnifications, because it's not really magnification, is numerical aperture of your microscope, but nevertheless. So in transmitted light microscope, which is what we use for earning our bread, a point of light is not seen as a point of light, it's seen as a series of energy, ripples of energies that go from negative to positive. You know, this is a 3D interpretation. And there is a cone where most of the energies is going. This is a single light source, a single point light source, but it's spread. And then there is these positive and negative ripples. Now, depending on the quality of the system, this central peak is going to be narrow and very high or broad. So these are the airy discs, not because they're made of air, but because the guy that described was George Airy. And William Stratt, who is a Nobel Prize winner, determined the reason why we see two different light sources or one single point, and it depends on how much trough there is between the two peaks of light. And then the third element of this, which makes you understand that it is not the magnification, but is the numerical aperture of the system, is that it doesn't matter how much you magnify it, but how good the lenses are. And Ernest Abbe is the person that defined the quality of the optics by creating this numerical aperture. The numerical aperture can be transformed into what is the resolution of the system. And here you have three different series of lenses, achromat or panachromat or pan-apochromat. And you can see that the numerical aperture is quite different. For the same magnification ×4, it could be 0.2 or 0.1. And the higher the numerical aperture, the better the resolution it is. Now, I'm telling you these things because conventionally, even I thought, well, if I double the magnification, I see thinner lines. But that's not the case. So look at this ×40 and ×50. There's 50% increase. The numerical aperture hasn't changed. Stays 0.95. And the power of resolution stays the same. So it doesn't matter at a certain point whether you increase more. And in fact, between ×20, that's double. ×20 and ×40, twice as much magnification, but the numerical aperture is very minor increase of the numerical aperture and a little bit more increase in resolution, not a doubling. Okay, so that's the point to consider.
We have two questions.
Excellent.
First one, do you think that looking at the intimate mechanism of HER2 amplification could separate the responders from non-responders to traditional anti-HER2 therapy?
Yes, I think so. But do we have a means to do it? This is something that always puzzled me. Why is it that we keep measuring expression of HER2 and we don't measure expression of molecules that tells us the pathways are activated?
Exactly.
And that's the way it is. We are just pathologists. We're just reading samples.
The second one, should we annotate HER2 ultra low status in our reports?
So I think ultra low is yet to be approved in many countries. Of course, people that know me know that we do things ahead of time, so we are annotating our reports with it, because sooner or later will come up. But in any case, I think EMA might have approved the ultra low for hormone receptor positive. I'm not entirely sure, but yes, I think so. I think this is a way of letting the oncologists know that things are changing and getting used to this terminology. Okay, so let me show you something else why I think you need to understand this magnification rule and the resolution, power resolution. Because you see, you could even use higher power, but originally in Joseph paper, he was using time 40, but years, several years of experience with PD-L1 has shown us that we need to be careful about using very high magnifications. And I'll show you these checkerboard illusion. Those that follow our courses already know this. I apologize. So this is not a trick. This is an illusion. This is to show you how your brain messes up with you. So that's the checkerboard, and there is an object on the checkerboard, and there are dark and light color squares. And I want the checkerboard illusion is about these two squares, A and B. So this is clearly a light square, and this is clearly a dark square. Okay, so I've copied the intensity, and I made a circle, copied the intensity of A and duplicated. So these two are the same intensity, and they are the same intensity of A. So if I put this circle on A, it will be the same intensity. We all agree?
Indeed.
If I put this on B, it'll clearly be darker. Yeah?
Yes.
Okay, that's what happens.
I must confess, I didn't believe it either, but he was doing in slow motion with me, and yes.
Yeah, this is true. I'm not a trick. I'm taking it there and I put it here.
Indeed.
So what is this? Is that our brain, doesn't want to upset us. It needs to portray reality as good as possible, and it knows that must be a wide square. So he's telling me it's a wide square,
Indeed.
even if it's not a wide square. So be careful, because sometimes your brain tells you there is a line of staining, and you really need to question yourself. Yeah. Is that staining?
Indeed.
Is that?
That's why we need to filter.
Okay.
Yeah, I will interrupt you. We have another few questions, an avalanche of questions, a little bit.
Yeah.
First one, should we recommend FISH test for patients with low HER2 1+?
So what do you think?
No.
No, why?
Because we don't have a threshold over there, and what are we trying to discriminate between what and what, between a 0 and a ultra low? We do not have studies. Maybe further on, we will have another test that will be able to discriminate and will be able to just point out to this category by itself, the low, but otherwise.
But not in situ hybridization,
no.
because in situ hybridization is based on the principle or on the observation that overexpression of the protein is by and large dictated by amplification of the gene, but normal expression or slightly enhanced expression of the protein is not related to amplification. So there is no way of doing it.
Then
tell me.
We do have, it means patient can still respond to trastuzumab. We are talking about a different drug here.
Exactly.
It's an HER2. So trastuzumab is for the 3+ ones.
Okay, so maybe it's good to take a little yes. So trastuzumab is a monoclonal antibody that has been humanized, and it binds to the HER2 molecule on the surface of the cells and somehow disable HER2 function. So it's a direct effect on HER2, and HER2 in those patients with amplification is an oncogenic driver. On the surface of cells that are not using HER2 as an oncogenic driver, they will be HER2 molecules because these are epithelial cells. You can target these with this antibody drug conjugate. So the Herceptin molecule now is just a lorry. It's a lorry that is carrying a lot of molecules of chemotherapy, which are bound to the Herceptin. They are once the antibody binds to the surface receptor, the receptor is internalized, and then some enzymatic, some protein enzymes that are within the cells cleave the bond between the chemotherapy agent and the antibody, and then releases the chemotherapy. So it becomes active. So it's a way of delivering a payload of chemotherapy inside the cell. So these are the two differences, yeah.
Then another question, can the evaluation of intensity using microscopy and digital images be different?
So yes. Absolutely, 100%, because the digital images will depend on the quality and the type of scanners you have, and also on the quality of the system that reproduces the picture. So your computer.
And I always said, be cautious what kind of laptop and what kind of resolution your laptop or computer uses. It can be different, definitely can be different. And the last one, talking about optics and resolution, do you think HER2 low, ultra low can be diagnosed confidently by AI? Some of the very weak staining can be confused with artifact on scanned slides.
Yes. So yes, this is a very good point. And I think that we are excellent AI machines, as in we pathologists, who are very used to understand what is an artifact and what is real. And so probably we will perform much better than artificial intelligence. At the moment, there are no validated artificial intelligence programs that can resolve the problem. So at the moment, the best computer we have is the pathologist. And all we need to do is make sure that the pathologist understands how to put together the data.
I can see someone uploaded 2 pictures. I promised, I had a quick look. We will talk more about, let's say, at the end of the presentation and make it, but yes, definitely we'll touch base on this as well.
Okay, so we talked about staining intensity. It's important to make sure that everybody understand staining intensity, so that when we call something weak staining, everybody agrees. When we call something strong staining, everybody agrees, because that's how we build concordance. Now, distribution of staining. I don't think this is very difficult. It's kind of complete versus incomplete, or if you want, circumferential versus non-circumferential. So in a cartoon, that's circumferential, and that is interrupted, non-circumferential, discontinuous. A little bit of cautions, because we understand now that there are certain types of breast cancer that secrete, that have luminal surfaces that secrete, that do not express receptors on this surface. So now we become more and more aware of this U-shaped. And U-shaped is very equivalent to circumferential. Yeah. So that's the only thing to think about.
And this usually we are finding in the micropapillary pattern.
And yes, so you need to obviously marry what you see by immunohistochemistry, what you see by morphology, you know, that's also important. Okay, now something new, because I really like always something new. It's not that new, but I mean, it's new for most of us. And this is my something new. Is if you go to underground, you will see these things, mind the gap, you know, written on the floor, etc., etc. Because I think the gap is important, okay? So why do I think the gap is important? So let me show you something that tries to explain what we actually see on the microscope. This is a study that uses QSML. So this is quantitative single molecule localization microscopy is an interpolation. There are fluorophores that are in cages, they're activated or photo bleached, etc., and the computer works out the exact location to very few nanometers. So a very powerful technique. You can't use it for routine. It takes, I don't know, 3 weeks to get a photograph or a sample, doesn't matter, but it shows us a glimpse on what it is, you know, how to correlate what we see under the microscope to what really happens. So I've always been told that on a membrane, the receptors are distributed equally all around it. But actually, that's not true. Using this technique, you realize that about 50% of the receptors, in this case is HER2, they sit in clusters, you see? Now, if you have different densities, and these are three different cells with three different densities, the clusters are more sparse, but they're still in clusters.
Yeah.
Now, what's going to happen when you stain a single, this dot is a single molecule, this is amazing. You see one molecule. Okay, anyway. What happens if you stain by chromogen one of these molecules? You see nothing, because you deposit chromogen on there and there is too little for you to see. I think you start to see staining the moment there are clusters, and the moment this cluster deposits enough chromogen to be visible with your microscope. So a way like an ink spot, you know? And then if your ink spots are sparse, you may not see, or you may see discontinuous. But if the ink spots are close to each other, you start to see continuous lines. You see, this is why I think the gap is important, because the gap is an expression of how many molecules there are on that cell, you know? Okay, so what I wanted to tell you is that although everybody, guidelines, etc., say complete versus incomplete, I think is going to be important uniform thickness or variable thickness, because the number of receptors will dictate that. Okay, so
it's good because these are recorded presentations. So after the new guidelines will be published, and it will be like, we told you a while ago. Okay.
But Simona, I told you many times, you know, we look at guidelines they say, oh, what shall we do? Let's look at guidelines. Yeah. Guidelines is a photograph on how we used to work 2 years ago when we wrote the guidelines. But now we work differently, because in 2 years' time, we'll write new guidelines. Yeah. So first of all, you change the way you work, and then you write guidelines. Okay. So some examples of what you see. You see this variable thickness. You know, that's it, some interaction, but also not only interaction, but also the lines are not the same thickness, thin and thick. This is more of this variable thickness. Sometimes we call them beads on string, or perhaps some emphasis at the intersection of 3 or 4 cells, this bird fit. Okay, so guidelines. These are the new ASCO-CAP guidelines, September 2023, and this is my note for the most important new take-home message for immunohistochemistry. And you may think I forgot to write it, or maybe I wrote it with white ink. But let me tell you, there is nothing of any importance to take home from this. They even tell us not to call HER2 low, HER2 low. So let me show you the RCPAT guideline. More or less come at the same time. These are different publication dates, but they were written at the same time. I think here there is an important message. And the important message is that they say that there is a strong feeling that the concordance in appraisal of HER2 low tumors is dependent on the fact that we have good descriptions of patterns. We need to start to learn to recognize patterns. Indeed. Yeah. So I think this is a very good point. Okay, so let's understand patterns. Before HER2 low, because all these patterns are of low staining intensity and they are not mimicking positive, HER2 positive things, nobody cared. I think I used to call everything positive. I mean, 1+ or whatever it is, it doesn't matter. So this one is clearly not membrane. It sits in the lumen, maybe attached to the glycocalyx. I don't know what it is. This is a higher power. But if you notice, there are no lines between the cells, you know, and that's a telltale sign. If you want to understand what it is, look between cells. If you find line between cells, then I'm happy, it's membrane. Yeah. So this pattern, not membrane staining. Another pattern that I used to call 1+ is this one. But it's a bit bizarre that is always between the tumor cells and the stroma. A bit bizarre, okay? That's a higher power, you know? This is not scored as 1+. This is scored as 0, because this is now referred to basement membrane-like staining. Whether it's basement membrane staining or not, I don't know. There is no real data, but for the practical purposes, in the clinical trial, this was scored as 0.
And again, you don't have staining in between the cells.
Well, every now and again, you may see a line here, but this stronger staining definitely not.
Yeah.
Okay. Now, this is another pattern that is cytoplasmic, clearly cytoplasmic. And some of us are tempted to say, but look, I think I see lines here. Yeah. Remember that checkerboard? Think twice before saying, I think there is a staining here. Okay. Because this can be created just by the interface of two cells. So be careful. And sometimes the staining, cytoplasmic staining, can be weak, but also recognize it as cytoplasmic staining. Cytoplasmic staining, in this case, is diffuse, but sometimes it's kind of focal, but it's still within the cell and it's fuzzy.
Yeah.
Okay, this is not membrane staining. Again, maybe here is membrane staining, but in general, be quite discriminatory, be quite difficult to accept membrane staining, as a question. So sometimes, despite the fact that there is cytoplasmic staining, many of us would probably agree that there is membrane staining here. So, every circumstance needs to be evaluated accordingly, and you need to use your experience as a pathologist to come up with the correct diagnosis. This is also an example of granular cytoplasmic staining. Obviously, it doesn't count, nor does the nuclear staining count for that. Okay, specific pattern. And this is also what we need to learn, because the recognition is not just mechanically, I see membrane staining, I count this, but I actually see a pattern that I recognize as 1+ or 2+ or 3+. This is clearly a 3+ pattern. We couldn't care less because this is DCIS, but I would like to show this picture because you see here these little early invasive tumor cells coming out, spinning off the DCIS. So strong, continuous, diffuse, nice. And that's also the hallmark of the greatest majority of HER2 amplified tumors. Indeed. Because it's an early event. There are some that are very patchy, but they are more rare. We talk about basolateral staining. Basolateral staining can be strong, maybe also associated with cytoplasmic staining, and you need to use your discretion on whether you think you can score it or not. I think probably most of us will say we'll score this one. Yeah. And again, also this case is circumferential with membrane staining. We can score that. Now, discontinuity. An emphasis in little parts of the cells and less emphasis in the other. So to me, this is a very classical example of 1+ staining pattern. Yeah. That's what it would look like. Some people, lots of people, call this 2+. Yeah. Again, these beads and strings. This is a classical 1+ pattern. More 1+ patterns. You see these interruptions, discontinuity, unevenness. None of these have strong staining intensity. They are weak or moderate. Some of them are U-shaped. Yeah. But actually, this one doesn't even have a nucleus, so I can't even count this one. Anyway. So now, this is something that in the past we never really paid any attention because it didn't matter at all, but now it matters with the ultra low and low, very, very weak membrane staining. If you convince yourself there is membrane staining, you need to recognize it.
This is a little more tricky because of the faint cytoplasmic as well.
Again, more weak. So now there is a little bit more focus about very weak membrane staining. Here again, looks like weak membrane staining. This is a ×20 photograph. At this point, let's put a higher power. Convince yourself that this is membrane staining. Yeah. More weak membrane staining. Discontinuous. Again, Crowfit's patterns. These are all the patterns we need to learn. Sometimes there are pictures like these.
Be cautious with this kind of specimens where you can see the nucleus like this, where you can tell has been some poor preanalytics or some issues with preanalytics. Yeah. be cautious with these cases, even if this is a 1+ staining, and I do agree. On this kind of cases, I would be tempted to say, okay, I'm telling it's a 1+, let's reflex it, because I do not think it's a very good pre-analytics here, and we might be surprised.
So, and that's interesting. And so Simona is now telling us, you know, sometime the scoring pattern is 1+, but still
you don't need to call it 2+ to reflex it. You can call it 1+ IHC. However, I have some reservations regarding the pre-analytics, so I'm calling it indeterminate. So
and I want ish. Yeah, fantastic. So here there is a confusion, because definitely there is membrane staining, quite delicate membrane staining, but there is also fuzzy cytoplasmic staining, you know. So you know, it's very easy in a pattern like this to say 2+, but actually this is not membrane staining, the one that we see. Again, poor pre-analytic, I think. So, okay, so we looked at staining patterns. So how do we work the algorithm for interpretation? It looks like this. So it's staining intensity magnification rule, complete or incomplete, and amount of staining. Okay, so the magnification rule, so you see it's a progressive thing. You look at the section at low power and you ask yourself, do I see any lines? Yes, excellent, very good. Are the lines complete? Yes, fantastic. Is that more than 10%? Yes. Wow, this is a 3+. Yeah. Is it less than 10%? Well, then, or equal 10%, I think I'll do ish. To be honest with you, most of us, if we see heterogeneous staining, so even if it's more than 10%, we say, I think I'd like to see an ish here, just in case, okay? So this is a guidance, but by and large, you could report it with 3+, even if it's 20% of cell staining. If it's incomplete, and this is not in the guidelines, if it's incomplete, you need to recognize this is odd, because what gives you strong membrane staining, usually it gives you also linearity. If it's incomplete, something is amiss. Don't dismiss it, you know, reflex it to ish. And we've been caught out that some of these tumors have amplification, and something has gone wrong, pre-analytics, your immunohistochemistry, I don't know, the time of the day, the lunar cycle, whatever it is. So remember the incomplete. Okay, so you don't see any membrane staining. It means there is no strong staining at ×4. That means you need to drop into ×10. Once into ×10, you cannot get here. That's no longer accessible. At best, from here, you get here to 2+. That's as best as you can hope. And to get 2+, you need to have complete membrane staining in more than 10% of the cells. That's what it is. To be honest with you, it doesn't matter if you see it at ×10 or at ×20, because the algorithm is the same. It's the 10% now that is the problem. You cannot go up here. Once you drop down, you cannot get to 2+. And to get to 2+, all you need is complete staining in more than 10% of the cells at this magnification, at this staining intensity. Otherwise, it's 1+. And now we added the complication that there is incomplete, or even complete if you want, but with less than 10%, and then we will have the HER2 low here. So this is better annotated here, the ultra low, better annotated here. So we've done all these exercises. Please understand that in a tissue section, except when is strong staining everywhere, there will be some cells that stain that you can see at ×10, some more cells you see at ×20. There is heterogeneity there. So you need to take this into account. So once you do all these things, you work out your immunohistochemical score, and then you can put it into a category. And depending where you are in the world and what your oncology uses, then this may change. These names may change as we go along to be more representative. So there is another caution. I can't remember what this caution is. This caution is exactly like, okay. So in general, 12, 14%, depending on where you are in the world and what kind of breast tumors patients you see, screening patients, symptomatic patients, etc. But 12 to 15% are amplified, HER2 positive. About 10% of the rest overall, they will be indeterminate, 2+. Of these 10%, about 10%, so 1%, 10%, will be amplified. The rest will not be amplified, okay? So look in your practice, because if in your practice you have 25% 2+, 40% 2+, 60% 2+, there is something wrong, okay? So I have to admit, we don't have 10% 2+. I think our 2+ are probably 16 or 18%. And there will be reason for it. But, you know, if you're traveling at 40%, there is something that you need to look into, okay? Indeed. So one thing that you should avoid is to stop calling 2+ things that for which you want to do ISH, but for other reason, because it's substandard, because there is a history. This was a history of somebody with positive breast cancer that is now is negative. Whatever it is, it doesn't matter. Exactly. But report it as indeterminate, because otherwise, you know, your data, your audit will show that you report too many 2+. Yeah,
indeed.
Okay, so we are now
very late.
Very late. We are now going to do some case studies, and Hannah will help us with these. The current task is to categorize the case as a 3+, 2+, 1+, or 0 with membrane staining, ultra low, or 0 no membrane staining, null, for the purpose of this exercise. So 5 boxes. I will show you some pictures. They will look like that. This one here. So they will all be the same. Low power, times 5, times 10, times 20, times 40. And you need to use the algorithm. Let's do this together for this person. So times 5, I see brown, but not much. I don't think I see lines. So no strong staining. Times 10, I see lines. Okay, this is a moderate staining intensity. Are they circumferential? No. It's not 2+. I'm going to look at it a little bit more at higher power if I want to, yeah, but clearly it's not circumferential. It's clearly more than 10% of the cells. So this case will be 1+ for me.
Indeed.
I will show you also a very much higher power that show that in reality, this staining is not circumferential because there are gaps. And remember, you would need 10% of these cells to be circumferential to call it 2+. So that's how it looks like. And now we will show another case, and Hannah will put a poll. You need to click and submit quite quickly, because otherwise we'll be waiting. For those of you that thought this could have been 2+, this is the ISH. The ISH is not amplified. Okay, case 2. Anna, put the poll up. That's the poll. And you can, we do it as well. Submit. You need to click where you think your answer is and then press submit. And Anna is keeping track. And this is very quick, so Anna will terminate quite quickly. Okay, and then she publish. Okay, so what do most people think? Most people think is 0 low.
Ultra low.
Ultra low, and it's half and half. Okay, let's close this one. What do you think, Simona?
Yeah, that's a very good question. Indeed, with it is more than 10% or less than 10%. There's no membrane staining. I mean, we cannot clearly see a times 5, a times 10, maybe, yeah, a little bit.
What about
this? I think it's in situ, though.
That's in situ. You're
I
right.
do think it's too.
Yeah.
So here I do see
not
exactly
so
this.
Yeah.
It is membrane staining, so it can be 1+ or ultra, like majority said. So I would like to see the whole.
We need to study the whole. Obviously, this is a game. Obviously, this, you need to press this one. Obviously, this is a game. Obviously, these are just pictures. The case was called 1+ because probably there were enough.
Yes, exactly. So I do think the people that scored the ultra low. Yes.
But those that scored 0 with no membrane staining, no, there is a little bit of membrane staining.
Yes.
Okay.
It is.
Let's do another case. I think case 3. And Anna, very good, Anna. Well done. Yes, you can score this one. I don't know what you think.
Okay. Quick.
We need to do 70 cases in the next 5 minutes.
No, it will be way less. Okay. Yeah. Share result. IHC 0, no membrane staining. Okay.
Okay, so between 0 no membrane staining and
5 no membrane staining.
Yeah.
Times 10, I agree, no membrane staining.
Times
20. I think it might be something here,
Yeah.
which here at the low power, I think there is,
Yeah.
to be honest.
Okay,
Oh.
so the down arrow. Yeah.
Eh,
Possibly convincing.
I
So,
would call it.
so this
Now,
would be a case that you need to recognize for ultra low. Yeah,
yes.
fantastic.
Apologize for the
Somebody has written, we
Probably
knew
us,
how
but
to
delete,
this, but I don't
we'll
remember
see
that.
it for
That's
the
fine.
next one.
Okay, next case, number 4. Anna. Excellent. So remember this stepwise approach and come up with an answer.
People scored 2+.
Okay, some people, majority scored 1+, but some people scored 2+. What do you think, Simona?
Times 5, I would not say I can
Nothing?
see any membrane staining. Times 10, I'm still even struggling, maybe here. So it's very occasional.
Yes, so
If
you
it
know,
is.
so you know when I say, do you see membrane staining times 10? I don't mean strain yourself. I mean comfortably.
Yes.
That something that nobody will object to
Indeed.
it. You know, I think I can say times 20.
So we are already in the week.
Yeah.
And now the question is
it circumferential? You can put a higher power still. Clearly not circumferential.
Here is missing gap.
Yeah.
Gap.
So if it's not circumferential, we cannot get to 2+ unless it's strong staining intensity.
Indeed.
Yeah. Okay. So 1+
Weak
for
and
us.
occasionally, very occasionally moderate intensity, but anyway, it's discontinuous.
Okay.
The
Next
last one,
case.
the last one.
Why last one? We want to do more. Okay. So Simona, you score this.
I can score this. I'm scoring. Why I'm insisting now, because I know the order, because I really wanted this, the next couple, and then
Let's
probably
do a few more. I know that we are a little bit.
we don't have time, everyone.
Time.
No. We are ending.
No. We'll stretch a little bit.
No.
Okay, very good. So it's between 3+ and 2+. Okay, let's see if I can make it 3+. Can I actually, the 3+ needs to be done here at times 5, okay? Hand on heart, I can see the membrane staining at 3.
Indeed,
at 5.
I agree. I completely agree.
This is not circumferential. It is definitely not circumferential. And I can confirm it's not circumferential when I go a high power.
Yes.
You know? It is not circumferential. There are gaps, yeah? So the only way for me to call it 3+ was that if I see more than 10% circumferential staining here, that's not the case. So you could score it 2+.
Yes.
I think Simona scored it 2+. I recognize in this staining pattern a 1+ pattern. But that's fine. You know, 2+ is not a problem. Because 2+ means that D-dish will tell us what it is.
Yes.
That's fine.
Agree.
I don't disagree. That's the D-dish.
Agree. And it's a negative D-dish.
Yeah.
Completely agree.
Okay.
However, I would not be comfortable to say this a 1+.
Okay, that's fine.
And with that, keep in mind, this is a definitely 3+. Yes.
Now, they want to cut us off, but I
yes,
want to do
I know.
A few more cases.
No, I want.
Okay.
We can skip upon this one.
Why? Well,
because it's a beautiful case, but it's a definitely 3+. This is how a 3+ by the book should look like.
Okay.
A times 5, strong intensity, complete.
Fantastic. Okay,
beautiful.
let's do the one after. Okay.
Okay.
So this will be the last one.
Okay.
No. Yeah, we can.
Okay, score it.
No. Okay.
Everybody score this. It may not be the last one, and
no, it is because we are at the time and we need to have the session on HER2 dualish.
Okay, so everybody here agrees 0, and maybe one or two thought it was ultra low. Okay, Anne, but my session on dual-ish is much shorter. Can I get one more case?
I don't think so, because it's not the same people that will join the next session. And we would like to remind everybody that the proficiency test open now. So you will be able to access cases and score them. And we will reconvene in 2 weeks from now for a Q&A session where discordant cases could be also discussed. So see you, thank you very much, and see you in 1 minute for the next